As the aging Canadian population grows, we are seeking solutions as to how to age successfully. In this inaugural online Logger lecture, Dr. Stu Phillips will explore the traditional as well as the less tangible, but perhaps equally as important, benefits of being physically active.
Unstructured search, and these algorithms were designed
Hi, my name is Stu Phillips. I'm a professor in the Department of Kinesiology here at McMaster University. Welcome to this online Albert Logger lecture entitled Move It or Lose It, where I'm going to share with you some of my secrets and some of the secrets that we've learned in the last 10 years around why being physically active is probably the most important thing you can do as you age and how to age successfully. So let's get started with the presentation. It probably wouldn't surprise anybody here to know that in 1950, with only 13 million people in Canada, that our population pyramid looked something like this. It was in fact pyramidal in shape. If we fast forward another 30 years to 1980, you can see the bulge that we now refer to as the baby boomers. Here we are in 2019 at almost 37 million people. And you can see that the shape of the pyramid really isn't pyramidal anymore. And this is a projection of what our population will look like in the year 2050. Certainly not a population pyramid anymore, and highlights that not only in Canada, but globally, people are aging. Quite simply, over the past 100 years, we've added about 30 plus years to our life expectancy. And it's this single fact that is changing almost every single health policy, government plan, as well as personal and economic, as well as health planning that anybody has. I'm often asked how old is old, and so there are some definitions that I'll share with you. People who are between the ages of 65 and 74 are considered to be the young old. The middle old are between the ages of 75 and 84, and the old are those that are 85 and older. Please be aware that the average life expectancy for men in Canada is now around 80 years, putting us in the top 10 in the world. Women live on average about 4 years longer, but a lot of that time is spent in institutionalized care. So a lot of the messaging I'm going to give about being physically active and keeping people healthier for longer probably applies more so to women than it does to men. How do we define what we call active aging, or what some people call successful aging? Well, the World Health Organization actually has a definition, which I'll share with you here. Active aging is the process of optimizing opportunities for health, participation, and quality of life as people age. It refers to continuing participation in social, economic, cultural, spiritual, and civic affairs, and it aims to extend healthy life expectancy and quality of life. It refers to maintaining autonomy and independence. So that's rather a wordy definition, but if you distill this down to its basic elements, I think you can say that it includes health, quality of life, healthy life expectancy, participation, autonomy, and independence. When we think about all of those factors, what we really want to be able to do then is age and have quality of life in the years that we spend on this planet. So what is it that Canadians have to worry about? When we look at the leading causes of mortality in men, it might surprise some people who are used to the common definition, or the common expression that the leading cause of mortality in men is actually cardiovascular disease. And that's no longer true. In fact, the leading cause of mortality in men is cancer, all types. That's not because more people or less people, are getting cardiovascular disease. It's because we're actually better at treating it and keeping people alive for longer. And then unfortunately, they die from something else, and that would be cancer in this situation. For women, the message is not all that different. In fact, the leading cause of mortality is still cancer, followed by cardiovascular disease. And if we split out stroke, even the two of them together don't equal the number of deaths that are a result of cancer. The problem is, it's not just about mortality, and I'm fond of saying that the rate of mortality is holding constant at 100%. But it's really about the quality of life that you enjoy while you're here. So much of what I'm going to speak about then is not necessarily looking at the causes of mortality, but reducing your risk of getting these diseases prematurely so that you don't experience a decline in quality of life. In that vein, I'm asking the question here, which of these chronic diseases is associated with a reduction in health-related quality of life? Cancer, heart disease, stroke, lung disease, and diabetes. Quite simply, the answer is all of them. And I'll add to the list conditions that are chronic and in aging, things like osteoporosis and osteoarthritis. All of these diseases have associated with them a reduction in health-related quality of life, such that when you have these diseases, something in your life is affected. It could be a mental health issue. It could be related to the treatment burden. It could be related to the stress that your caregiver or your spouse feels because you have these diseases. It really is hard to define, but it's been shown time and again that people who have these diseases, the quality of their life is diminished. I'm going to ask you a hypothetical question, and the scientist you see in the top right corner is a gentleman named Frank Booth, and he posed these series of questions. What if there were a treatment that would lower risk and reduce symptom progression for all known chronic diseases, cancer, cardiovascular disease, stroke, and type 2 diabetes? And it works regardless of your sex, your race, or your pre-existing risk profile. It already has a large evidence base on which to base these recommendations, and it would save the healthcare system billions of dollars and cost comparatively little in return. Now, the interesting point about this treatment is that opposed to the side effects that you often receive with certain medications, the side effect profile of this treatment includes better prognosis for a variety of unrelated ailments, including depression, dementia, both all-cause and Alzheimer's related, self-efficacy, and suicide incidents. I think if we combined all of these things and I asked you if we could put it in a pill, would you take it? I think most of us would answer yes. Unfortunately, it doesn't come in a pill, but exercise or physical activity is the single most effective lifestyle change if you're not currently doing it, or if you're doing it to do more, that can alleviate your risk for all of those chronic diseases that I mentioned and improve your health-related quality of life. So let's talk a little bit about physical activity. Physical activity is defined as movement of the body by skeletal muscles that results in energy being expended. Under this umbrella definition, activities such as walking, gardening, even going for a longer walk in a parking lot if you park the car further away from the store, for example, are physical activity. Exercise, on the other hand, is planned and structured activity that is repetitive, done with the aim of improving your physical fitness. So there's a distinction between the two, and I won't necessarily say that one is better than the other, but the bottom line is if you're not physically active, then you're definitely not doing exercise and you're not availing yourself of the benefits that I'm going to talk about here. So for older adults, what are the recommendations that we're supposed to follow? We have physical activity guidelines here in Canada that recommend a number of very strong evidence-based studies that talk about how much physical activity we should do. I think most of us are familiar with these recommendations, but I'll just review them with you here. First, take part in at least 2.5 hours or 150 minutes of moderate to vigorous intensity aerobic activity each week. Spread out the activities into sessions of 10 or more, although we may see a change in this recommendation down to smaller intervals. And then finally, the recommendation is that it is beneficial, and you can see my type there. I've crossed out beneficial, and I said I think it's essential that you add muscle and bone strengthening activities to major muscle groups at least twice a week. And this will help reduce incidence of falls and a number of other things, which I'll reveal to you later. So this helps with your posture and balance. And there's two important footnotes here. It's a dose response, and I'll show you exactly what that means. In other words, doing a little bit of physical activity is beneficial. Doing a little bit more gets you a little bit more, but the benefits begin to diminish the more you add. When we talk about strengthening, we should also talk about flexibility and balance, which are really important components of being strong as you get older. So in this figure, you can see that health benefit is plotted as a function of the amount of activity that people do relative to their baseline. So the red part of this curve here shows that if you had a very low physical activity prior to engaging in something, you would experience a tremendous health benefit. In fact, it's these people that we see the biggest benefit in terms of the reduction in risk for chronic diseases, more so than anybody else. So going from doing nothing to doing something is associated with the biggest health benefit that we know of. And you can see as we move up the curve here, you can see that the benefits begin to diminish. In other words, the dose, as it gets larger and larger, the more activity that you do, the benefits that you reap become smaller. So from a public health standpoint, it may make a bigger effect on a lot of chronic diseases if we can get people who are physically inactive to become even a little bit active. So the question then is the most viable foundation for active aging being physically active. I'm going to talk first about aerobic exercise and something called cardiorespiratory fitness. Cardiorespiratory fitness refers to the ability of your body to pump blood and oxygenate it and get it effectively to peripheral tissues, particularly things like muscle. The manifestation of this that you might have heard of or had friends that have gone through this is to put people through what we call a stress test. Imagine that you're riding a bike and the hill keeps getting steeper and steeper, or you're walking up a hill, the same sort of thing. And this challenges the cardiovascular system. I think an interesting point to make is that when we talk about physical activity, the measure of cardiorespiratory fitness is now considered to be as important as the other four vital signs. So your blood pressure, your respiratory rate, your heart rate, and your body temperature. In fact, this is a recent position stand from the American Heart Association saying that the cardiorespiratory fitness is a potentially strong predictor of mortality than established risk factors such as smoking, hypertension, high cholesterol, and even type 2 diabetes. And I'm fond of saying that exercise is a tremendous forgiver of sins. And even if you engage in those activities, things like smoking, or you have high cholesterol or type 2 diabetes, but are physically active and your fitness level is high, then your risk associated with those diseases is diminished even then. I'd just like to take a quick moment, remind anybody if you want to ask questions, there's a Q&A button down at the bottom of your screen. If you'd like to click on it, type a question in there, and at the end of this talk, we'll be happy to field those for you. I want to talk a little bit about cancer. I don't think that most people realize how much benefit physical activity has in reducing your risk for cancer. This is an interesting observational study of the amount of leisure time associated with the risk of getting 26 of the most common types of cancer. This plot shows you that your ratio or the hazard or essentially the odds of getting these diseases, these types of cancers, is diminished the more activity that you do. I've drawn a red line here to show you that for the cancers below this line, the risk is not significantly different from zero, but 13 out of the 26 most common cancers here, your risk for getting them is reduced if you're physically active. And this is simply leisure time physical activity. This is not engaging in large body maneuvers that are, for example, part of exercise. These are simply people who are more active in their leisure time. Heart disease is probably the most well-known in terms of the diseases that is prevented by physical activity, but I'm just going to show you a little bit of data to prove to you that that's still a true point. Again, the same type of graph here, we're looking at a risk of getting heart disease as a function of cardiorespiratory fitness. So the fitter you are, this graph shows you all of the lines are shifted to the left, so your risk is less than 1. In other words, you experience a reduction in risk of about 17 to 18% of getting cardiovascular disease if you have a good level of physical fitness. Diabetes is the same message. In other words, the leading cause of adult amputation and adult blindness, which is type 2 diabetes, the risk of it is diminished the fitter you are. Not as many studies as you can see in this area, but the fact that the rhombus lies to the left, or in other words, you have a diminished risk of about 12%. That's an incredible amount when we consider that the amount of Canadians with diabetes is estimated or is diagnosed currently at about 1.5 million, but could be as high as 3 to 4 million people. In other words, there are probably 50% of the people out there that have diabetes, it's undiagnosed. So being physically active and improving your cardiorespiratory fitness reduces your risk of this chronic disease. I'm going to talk a little bit about dementia and Alzheimer's, and I'll say that this is very early data. The field is just growing, and it's an interesting fact that, again, the protective effects of being physically active and having a high cardiorespiratory fitness extend to something as disparate as Alzheimer's and Alzheimer's and dementia. You can see the graph on the left is what we call all-cause dementia, so non-Alzheimer's related dementia. And you can see that being physically active again, this is the group that's the most physically active versus the group that's the least, has a reduced risk of about 20%. That's an interesting statistic, particularly when you look at the graph on the right and you see this is for Alzheimer's disease and physical activity. Again, the same 15 to 20% reduction in risk. Importantly, I think you need to bear in mind that most drugs that we've trialed for dementia and for Alzheimer's related dementia have not done a particularly good job to date. So if somebody said that you could take a pill or receive an injection that would inoculate you against dementia or Alzheimer's disease, I think all of us would take it. But this is the effect that you're seeing here in this figure in terms of physical activity. This is to show you another view of those same data and to point out that, again, the reduction in risk that you see with all-cause dementia on the left and with Alzheimer's-related dementia on the right, that it's a dose response. So the more physically active you are, the lower your risk for getting both all-cause and Alzheimer's-related dementia. It's interesting to make a small comment on why we think this is the case. We used to think the brain was a static structure, but we now know that physical activity and exercise both modify the structure of the brain itself and a particularly important part of the brain known as the hippocampus, so related to things like memory. So we have evidence-based support for physical activity and higher fitness, lowering the risk and improving the prognosis, which is data I haven't shown you here, for heart disease, for cancers, for type 2 diabetes, for dementia, and, well, I didn't mention it, depression as well. And I think some of the later ones are probably a surprise to a lot of people. Finally, I'm going to talk about musculoskeletal fitness, and particularly as it relates to a syndrome that all of us at some point in our lives are going to suffer from, and that's sarcopenia. Sarcopenia describes the age-related decline in muscle mass and muscle function. I think a lot of us would admit that as we've grown older, it's a little bit harder to do some of the things, particularly that are related to getting out of a chair, going up a flight of stairs, even recovering from a strenuous effort. The manifestation of that is probably due to the confluence of two things. First of all, a decline in cardiovascular fitness and a decline in our muscle mass and our muscle strength. So how do we define sarcopenia? And there are a lot of definitions. I'm going to give you one definition, which I think is my favorite. Sarcopenia is described as a progressive neuromuscular syndrome that lowers quality of life in the elderly. It decreases the ability to lift loads, progressing to difficulty arising from a chair. It decreases endurance and leads to an inability to perform activities of daily living. The most functional lift that I describe to people in terms of moving a particular weight is not how much you can lift in a gym. It's simply, can you get yourself out of a chair without using your hands? Because if you can't do that, that action, simply put, means that you're at a much, much higher risk of being institutionalized. You can't get off a toilet. You can't help yourself. You need somebody there to help you. So we're talking about minimizing sarcopenia as we age. And I'm going to show you a conceptual graph of muscle mass and the strength or muscle function that's associated with it. So imagine that we had two individuals. The first individual in green has their peak muscle mass early in adulthood, and then it declines steadily. And you can see it's declining to the age of about sort of 85. And then the second person is a similar type of person, but their muscle mass declines a little bit faster. That's probably to do with their lifestyle choices, definitely whether they're physically active. It could have something to do with their dietary choices as well. And it could have something to do with a disease that they have that is limiting their ability to be physically active. Or it also could have something to do with their hormonal status. Regardless of which person you are, you can see that the person in yellow begins to hit a disability threshold, or in other words, an increased risk for disability earlier in their life than the person in green. So the question you should ask yourself is, which person would you rather be? It doesn't mean that you're disabled, but your risk for disability goes up. So what can offset muscle loss and aging? Well, no surprise, physical activity. The MRI scan that you see at bottom here is a 74-year-old sedentary man on the left and a 70-year-old triathlete on the right. Exactly the same height and weight, but you can see the difference in the amount of muscle that they have and the amount of fat that's around their muscle. One of the key figures that I like to show is this is a 5-year follow-up trial in a group of men from the Health, Aging, and Body Composition trial run in the United States. And it shows the difference between 4 groups of individuals and their leg strength and risk for mortality. What you can see is a number 170 on the right-hand side of this graph and 90. Those two curves represent the upper quartile, or the upper 25%, and the lower 25% of individuals. And you can see that the weaker individuals had a much greater risk for mortality over the 5 years of follow-up. The graph looks a little bit different for women, but it's remarkably similar in shape. The point here that I want to make is that where you want to be is in the group that has a strength of greater than or equal to 100 versus the group that is in the 60 range. Quite simply, being strong is a resistive factor against mortality. This is an interesting figure, and again, I think it sort of gives you some new information probably around your risk for cancer or mortality, both all-cause and cancer-related, and shows you quite simply that if you're over the age of 60 and you are in the strongest group, that your risk for cancer and your risk for mortality all-cause is lower versus a group that is not quite as strong. This relationship was built in men only, so we lack the data in women currently, but my guess is that it is exactly the same. I'm going to show you an interesting figure. We're told constantly that having high blood pressure or hypertension is a risk factor for a number of different chronic diseases. Stroke is greatly affected in terms of your risk by high blood pressure. Now, the interesting part of this figure shows you that in men with greater hypertension versus those that are weaker versus stronger, that being strong actually is protective, and through a mechanism that we probably don't fully understand, against your risk of mortality, even if you have high blood pressure. So you can see that being strong and being physically active is actually modifying your risk, even though you have a predisposing risk factor, in this case, high blood pressure. What about osteoporosis? Osteoporosis is known as the silent killer. It creeps up. We don't really know whether we have it. We can only detect it if we have a bone scan. Needless to say that women are at a much greater risk of developing osteoporosis than men, and particularly postmenopausally. I'm going to show you some interesting data. Exercise, and it doesn't matter whether it's aerobic or strength related, improves your bone mineral density at 2 sites that are very important sites that are often fractured in older women. The first site is at the spine, and the data that's out there shows that exercisers have 1% less bone loss than non-exercisers, and that people engaging in both strength and aerobic exercise had 3.2% less bone loss than those who did not. Quite simply, your bone stays stronger for longer. This is the same message both at the spine and at the hip. The interesting part is the rate of fractures is lower by almost half in the same individuals. Knee osteoarthritis or osteoarthritis, the wear and tear form of arthritis, is the bane of a lot of older people. There's no question about that. It's not a risk for mortality, but it's definitely a risk for reductions in mobility. And then reductions in mobility lead to a whole host of problems. So what can we say about physical activity and osteoarthritis? Quite simply, the message is exactly the same and often opposite to what a number of people think. The efficacy of treating osteoarthritis lies not actually in aerobic exercise, but in strengthening exercises. In fact, strengthening exercises both with or without weight bearing are effective for pain relief, so symptomatic relief in older people with knee osteoarthritis. And as the typeset shows you here, the most effective exercise among the three types is non-weight bearing strengthening exercise. And you can see the lady in the picture down there doing an incline leg press, pushing against some weights. And that's really effective, contrary maybe to what a number of people might think. Now, a number of people self-medicate and treat themselves for knee osteoarthritis using over-the-counter medications, analgesics like Tylenol or Advil, and they simply do that for a long period of time until the pain gets so much that they see their physician and they're looking for some other form of treatment. And ultimately, this is a precursor to probably somebody getting a knee replacement. So what does the data show us in terms of comparing exercise head-to-head against the pain relief from, say, over-the-counter analgesic drugs? The interesting part is that the pain relief is comparable between the two conditions. An effect size, which means sort of the magnitude of pain relief that people got, was exactly the same between taking over-the-counter analgesic drugs and being physically active, performing, in this case, it was strengthening exercise. So as the conclusion says here, the study provides evidence that knee osteoarthritis pain, the effects from exercise and oral analgesics are comparable. And I think that that would surprise a number of people who believe that being more active actually would aggravate osteoarthritis when the complete opposite is true. But here's a situation where the strengthening exercises actually are a little bit more effective than the aerobic exercises. So we have evidence-based support for strength in lowering the risk of mortality and morbidity for cardiovascular disease, for cancer, for osteoporosis, and for osteoarthritis. The last thing I'm going to talk about is fall risk. And I don't think that it would surprise anybody who's listening that a fall is a watershed moment in an older person's life. So we want to try and reduce people's risk for falls as much as possible. And there really is, when it comes down to it, only sort of one intervention that has been shown from an exercise standpoint to be particularly effective in this regard. And that's to practice balance or posture or some form of strengthening activity. Again, I'm going to show you a meta-analysis, which is a compendium of a large number of trials here. I'm just going to flash in on the bottom line. And what you'll see is that the risk favors exercise. So the more active you are, the stronger you are, the better your balance, the better your posture, then your fall risk is reduced. And we have no other means of reducing somebody's risk for a fall other than maybe clearing hazards so that people don't fall in the first place. So what are we going to do? I think that I'm going to give you a few tips for if you're uninitiated. So in other words, if you're struggling for why should I exercise or how do I do it in the first place, I think the most important thing is to find doing an activity that you like doing. It could be walking, it could be swimming, it could be cycling. It really doesn't matter. It could be strength training at the gym. It could be walking stairs. No problem, as long as you enjoy what you're doing and you can come back to it. And what's really important, I think that minutes count. In other words, increasing your physical activity doesn't have to be something that you go from 0 to an hour a day. That's a prescription for failure. But for going from 0 to 10 minutes is already associated with a large number of health benefits, in particular from a mental health standpoint. So the physical activity that you add to your day can be as small as 10 minutes in duration, and that would have a markedly protective effect. I think importantly, active time can also be social time. It could be a group activity that you participate in, or with your family or your friends, whatever it is that makes it enjoyable. Quite simply, find something you like, stick to it, and you will begin to see effects. You could get a membership to a gym. You could find a program that helps older or senior people lift weights, shows you how to do it in a safe manner, or you could choose lifting your own body weight. It really doesn't matter. So walk wherever and whenever you can. Take the stairs instead of the elevator. Carry your groceries home. It quite simply doesn't matter. Remember what I said. The biggest reduction in risk is going from doing nothing to doing something. What are the barriers? I think there are two important ones. There's a common misconception that to reap the benefits of to reap the benefits of exercise, it has to be vigorous, intense, draining, gut-wrenching, and if you don't sweat, then there's really no benefit associated with it. And nothing could be further from the truth. The bottom line is that physical activity comes in many shapes and forms, and as long as you're doing it and doing it in a repetitive and regular manner, that's what counts. The last part is a perception of risk that may be probably fostered to a large degree by healthcare professionals, and that is an exaggerated fear that's really a cognitive dissonance over the risks of physical activity in old age. In other words, I'm going to send this person out and it's a heart attack waiting to happen. Quite simply, it's true that being more physically active does increase your risk for a sudden cardiac event. However, I'm going to compare and contrast that against the risk of sitting and doing nothing. Quite simply, we know what that risk is, and that's multiple different chronic diseases, not just a heart attack. I think the risk by comparison of you experiencing an acute event in terms of a heart attack versus the chronic reduction in risk is more than balanced out. So I don't see these as barriers at all, and particularly if done in a supervised fashion and in a safe way, there is no risk to being physically active. I'm going to show you a quick quotation here, and it's one of my favorites from Ron Davis, a former American Medical Association president. And he said, and it's quite simple, if we had a pill that contained all of the benefits of exercise, it would be the most widely prescribed drug in the world. The problem is there is no pill, and there never will be. There will be pills that contain a small aspect of exercise, but never all of the global benefits that we've talked about here. So coming back to the question, is the most viable foundation for active aging being physically active? In my opinion, yes, it's the biggest part, but you have to move. I want to thank you very much. And at this point, I'm sure we'll be able to take a few questions. Okay, one of the first questions we have is, what kind of muscle and bone strengthening activities would you recommend for older people to engage in? Does it have to be weightlifting? The answer, quite simply, and that's a great question, is that we have an idea that the skeleton in particular responds best to loading, and the loading is in the form of some type of weightlifting. Now, the weight doesn't have to be external. It could be body weight. So for example, doing a squat, but just using your body weight and not engaging in having a bar on your back, or simply doing stair climbing activity. Each step that you take in stair climbing is in effect a knee raise, and you're pushing your body weight up with a single leg at the same time. It is probably best, however, if you could go to a gym and practice and engage in strengthening activities like the leg press that I've showed you before, and to do something for your upper body as well. So I think that it's important that you do something like that as opposed to something like walking, which is great for cardiorespiratory fitness, but not particularly effective for strengthening muscle or bone. Non-weight bearing activities like swimming, for example, while it's a great cardiovascular workout, you need to be particularly careful because you actually need to load the muscle and load the skeleton to get the benefits. Okay, our next question from Dan. What are your exercise recommendations for a person with an adrenal compromised system due to neurosurgery who has to exercise moderately so as not to overstress the system? Again, that's a great question, Dan. Pretty rare, I'll be honest. But the bottom line is that your personal feedback in terms of how you feel is really the situation where it's going to be how you feel in that situation and regulating, auto-regulating the amount of exercise that you can do. Despite having that condition, it's still, I think, unequivocal that exercise would be a benefit for you. Got another question here from Nada. Physical activity is said to lower risk of getting these diseases. My question is, if I have one of these diseases, am I already at risk? Would physical activity still be beneficial, or would it be too late? The simple answer to that question, Nada, is it's never too late. Even if you have those diseases or one of those diseases, the mitigation of the comorbidities, the other conditions that are associated with those things, would be particularly effective with physical activity. And at the same time, if you have one chronic disease, we're trying to delay the onset of number two. When you have multiple chronic diseases, then things get worse, and it is never too late. And so you get modifications in risk even if you have a pre-existing disease. We're talking about arthritis and back pain. They restrict movement due to pain involved. I play tennis 3 times a week with these ailments for the last 2 years, but I'm not sure I'll be able to this year as walking causes pain. There are still exercises I can do, so I do them. It's an interesting fact that I think probably about 75 to 80% of all Canadians will experience back pain at some point in their life. And arthritis as well, the wear and tear form of arthritis in multiple joints, knees, hips, shoulders, elbows, etc. Again, remember what I showed you in terms of the relief of pain that comes with being physically active, and particularly with strengthening exercises. So strengthening exercises for somebody who's asking this type of question would, I think, be particularly important. They don't require a large cardio or respiratory effort, and they actually reduce, not increase pain. Thank you. Oh, I've got a 63-year-old runner who's been running for over 30 years. I'm concerned about intensity of training. How many days per week do you recommend, and how hard? It's hard to make a generic recommendation, but if you've been running for 30 years, good on you. That's awesome. The point, I think, is that everybody has a particular threshold. It could be 5 times a week, 6 times a week. It could be as little as once or twice. The physical activity guidelines, the physical activity recommendations still are in effect. So try and accumulate 150 minutes of moderate to vigorous strength training twice a week, and use your own personal feedback on what your body tells you you're experiencing. If you're tired, and try and avoid pain at all costs. So I'm sure we're all familiar with no pain, no gain. I've changed that, and my basically axiom now is no pain, no pain. So I try and avoid pain at all costs. The bottom line is, when it's painful, people tend to back away from being physically active, and that's a problem. So how many times a week you should run at this point, I think it's completely up to you. Try and hit those physical activity guidelines. At the age of 85, Stephen says he's experiencing challenges getting up out of a chair. Is it possible to gain that ability through strengthening? Great question, Stephen. I'm going to refer to a really great study called the Fix-It trial, done by a group at Tufts University in Boston, showing that people who were nonagenarians, in other words, in their 9th and 10th decade of life, were able to regain strength with strengthening exercise, even at that age. So the system retains its ability to get stronger even at the age of 85. So the selection of exercises is modified, but it's all about the front quadricep muscles, the big muscles on the front part of your thigh, and trying to get a sort of a driving action, so up and down. So doing chair sits would actually be an excellent way to develop the ability and improve your capacity to get up and out of a chair. Stephen asks, what level of walking is considered moderate? Just a brisk walk of 4 to 5 kilometers per hour, which I do. I don't get out of breath, not even a little. So I think, Stephen, the answer to your question about maybe the health benefit that you get with that style of walking, so out of breath, is, that's not a requirement to get the health benefits that we're talking about. But quite simply, I showed you that you've gotten the immediate health benefits on the first part of that curve from doing nothing to doing something. Now, to get a little bit more in terms of health benefit, you either have to walk for longer, which might not be what I recommend, or walk a little harder. So if there are hills in the area where you live, or if there are stairs, and I think you might have seen a paper that came out and a press release from a colleague of mine, Marty Gabala, who showed that even a brief 20-second period of stair climbing, which can make people actually quite winded and out of breath, only very short, improves your cardiorespiratory fitness. So these interval type bursts, if you like, could be something that you could add to your walking. Steve asks, for walking, what recommendation do you have? How many hours per week? What speed, i.e. less than a 12-minute mile? Again, it's about the physical activity guidelines, and I don't think you can argue with the evidence for those. So the accumulation of 2.5 hours or 150 minutes in a week, whether you do that in 10 or 20-minute segments, half-hour segments, so that would be 5 half-hour segments 5 days a week, it really doesn't matter. The intensity begins to matter a little bit if you can't get that amount of physical activity in. It's true that you get a little bit more benefit the faster you walk, but then you can reduce the duration. So intensity and duration are inversely proportional to each other. If you have mobility issues such as drop foot, can you still reach good levels of activity? I walk with poles in the summer, but winter causes problems. That's a great point. This individual has drop foot, so they may have a problem ambulating. Their foot isn't able to be picked up each time, and so they walk with poles. And pole walking is fantastic. Nordic walking, absolutely awesome. The winter is always a problem for Canadians, and I don't think unless you've lived in this type of environment, you can really appreciate how big of a barrier to being physically active, snow and cold, etc., and sidewalks that don't get cleared actually are. Try and find a mall. Mall walking is quite popular. If you can, or if you want to, you can join a fitness facility. And if you can do that, then I think you can sort of solve a lot of your problems. But I'm going to be the first to admit that even myself, who I like to say I'm as physically active as possible, I have a hard time in the winter. So don't feel bad. It's common, but try and find the solution that works best for you. Okay, we have time, I'm told, for one more question. Ryan asks, what nutritional interventions in combination with resistance exercise can attenuate muscle atrophy or sarcopenia in an older adult? Great question, Ryan. Quite simply, the research that my group has been engaged in would suggest that a higher than recommended protein intake, consuming nutrient-dense sources of protein, things like meat, eggs, dairy, are particularly effective in promoting muscle gain when you combine it with resistance training. You don't necessarily have to consume supplements, which are a convenience, but the bottom line is if you can't find the protein in those foods, then supplemental forms are perfectly acceptable. So I want to thank you very much for joining us. I hope you enjoyed this Lager lecture. I'm told that we will have the presentation. We'll receive a brief 4-question survey. Please take a minute to fill that out and provide us with your feedback. This presentation was also recorded and it will be archived on the McMaster YouTube channel within a few days if you would like to rewatch or share with friends. For a complete list of upcoming alumni online and in-person event listings, visit alumni.mcmaster.ca and see event listings under the Meet People drop-down menu. Thanks again for joining us and have a great evening.
As the aging Canadian population grows, we are seeking solutions as to how to age successfully. In this inaugural online Lager lecture, Dr. Stu Phillips will explore the traditional as well as the less tangible, but perhaps equally as important, benefits of being physically active.